السلام عليكم. النهاردة إن شاء الله بإذن الله we will have our second lecture about Endodontic Surgery. We ended the last lecture with the root end preparation, and we compared both the traditional root end preparation and the ultrasonic root end preparation, and we said all the properties and the important properties of the ultrasonic prepared root end preparation. Today we are going to start with the root end filling materials. What do I need from a root end filling material? I needed to make a hermetic seal to seal the apex properly, to trap the irritants within the canal, either if there is a residual infection or irritants to be trapped within the canal to die, and promote cementogenesis and periodontal repair to regain the proper periodontal attachment. The ideal material should have the following properties. For sure, there is no ideal material, but materials that we have nowadays are trying to approach the properties of the ideal material. The ideal material should be easily manipulated, adapted easily, and have a good working time. It should also be dimensionally stable, which means it doesn't shrink or expand, so it does not affect the seal. It should provide a hermetic seal. It should be biocompatible, non-carcinogenic, non-porous, and promote healing. Also, it should be insoluble, doesn't corrode, and unresorbable. It should be bacteriostatic, because if there is a residual infection, it can kill it or at least attenuate it, and sterile. It should be radio-opaque, so we can trace it in the radiograph, doesn't discolor the tooth, and can be easily removed when needed for retreatment. What are the root end filling materials that we have? We have amalgam, gutta-perca, zinc oxide and genol, composite and dentine bonding agent, calcium phosphate, and the most recent are the MTAs and the bioceramics. As for the root end filling material, each material has advantages and disadvantages. No material, as we said, is ideal. We should select the material according to the case and according to its advantages, and trying to avoid its disadvantage. First of all, the amalgam. It was easy, adaptable, and biocompatible, non-resorbable, and radio-opaque. But unfortunately, amalgam shows initial leakage and secondary corrosion. It causes some staining of hard and soft tissue because of this corrosion. Actually, in its preparation, for retention, it depends on undercuts, which means more cutting of the root surface, which means more opening of the dentinal tubules and possibility for perforation. Also, some scattered particles are non-resorbable and may cause foreign body reaction. And as we can see in this picture, this is tattooing from the staining of amalgam that was put in root end filling material. The second root end filling material is the gutta-perca. How can I use the gutta-perca as a root end filling material? Actually, it can be used because the canal is already filled with gutta-perca. So I can only resect the root, just call burnishing the gutta-perca in the root apex, or I can heat a condenser and heat seal this gutta-perca. Some others tried to remove a part from the gutta-perca and inject thermoplasticized gutta-perca and burnish it. Actually, gutta-perca have a low seal. It's very moisture sensitive, and the apical seal depends on many factors such as the structure of the gutta-perca, the degree of condensation, the nature and amount of sealer, and there is also tendency of the margin to open, which may lead to reinfection and may lead to failure. Third material is the zinc oxide and genol. It comes as a powder and liquid to be mixed and applied in the retro cavity. Actually, it has a better seal than amalgam, glass ionomer, and hot burns gutta-perca, but it has moisture sensitive, show a little bit of leakage, and has an initial tissue irritation because of the eugenol content. Although it has most of the advantages of the ideal material, but the moisture sensitivity is a killing factor regarding the root end filling materials. After that comes the composite resin and the bonding agent. It's very challenging to put composite resin as a root end filling material because composite restorations always needs very good hemostasis and the field, and some of them depends on wet bonding, but actually the field of surgery is full of blood, it's full of moisture. To contain the moisture in the field of surgery is very tricky. It's easy to use for sure, and it has excellent seal because of the bonding, but the blood and moisture sensitivity is a killing factor also for composite resin and bonding agents. After that comes the glass ionomer with a very important property, which is the chemical bond to tooth structure, which we need very much to achieve a good seal. But actually also comes the killing property, which is the moisture sensitivity and the low pH. Then calcium phosphate started to appear. It's a radio-opaque material, it's insoluble, adheres well to the canal wall, and it's very good in promoting bone formation. It's very close to the ideal material for retro fillings. In the body fluids, it forms hydroxyapatite and it makes the restoration and the tooth as one unit. It precipitates some hydroxyapatite crystals entering into the tubules, making the restoration and the tooth as a one unit and very good for the seal. The latest generations of the bioceramics, the first of them to appear was the mineral trioxide aggregate, or as we see, the MTA. The MTA has excellent moisture tolerance. Actually, MTA works very well in the moist conditions. It adapts very well to moisture. It consists of tricalcium silicate, tricalcium aluminate, tricalcium oxide, and silicate oxides with a radiopacifier such as bismuth oxide to be able to appear in the X-ray. It has excellent biocompatibility, and it's a bioactive material. What's a bioactive material? It's a material that promotes periodontal repair and regeneration, promotes cementogenesis, promotes reattachment of the periodontal fibers into the root surface. So it's very excellent with its biocompatibility and with its seal. It has less leakage, for sure less inflammatory reaction, and it is alkaline, has high pH. And as we know from before, the high pH always induces hard tissue formation, so it's excellent for repair. But as we know, not all materials are ideal. It has a very long setting time, and its handling properties are a little bit difficult. It's a little bit tricky and needs someone who is used to using the MTA to know how to mix it well. MTA sets with hydration reaction, which results in a colloidal gel and forms hard structure. This hydration reaction that results in the hydrated silica gel, it produces crystals. These crystals crystallization occurs within the tubules that makes micromechanical anchorage. Let's imagine crystals. These crystals are deposited within the tubules, then they are growing, they anchor within the tubules. So it makes micromechanical anchorage, thus enhancing the mechanical properties and the sealing properties and producing less leakage. Also, calcium hydroxides dissociate into calcium and hydroxide ions, increasing the pH, and as we said before, increasing the pH or the alkaline medium inhibits bacterial growth and enhances the deposition of hard tissues. The most recent generations of the bioceramics after the NTA, emerging the bidentine, bioagarite, the endosequence, and calcium-enriched mixture. The new technology in these materials included the nanotechnology. The particles started to be nano-sized. What will be benefit from a nano-size? A nano-size causes better preparation, for sure less setting time, and less staining for the teeth. Staining may not appear actually in the periapical area, but if it was used near the coronal area, they are less staining than MTA. They work by formation of tag-like projections also and hydroxyapatite crystals that are deposited inside the dentinal tubules, forming micromechanical anchorage and a very, very, very strong bond. Also, they are bioactive, they are biocompatible with excellent periodontal healing and regeneration power. The procedures of root and filling. We ended up the last session with preparing the retro cavity. Now, if we can imagine, there is a bony cavity and the root tip projecting through it and a retro cavity in the root. The first of all I need to do is to dry the field. I use gauze to dry the field very well. And I use paper points to dry the retro preparation. The second thing, I should pack the bony cavity with a material for two reasons. First, to control the bleeding. This material should control the bleeding. The second thing is that I'm gonna put a retro filling material. So I need something in the bony cavity to prevent this material from scattering all over the bony cavity. So I should pack the bony cavity with either bone wax, epinephrine dampened gauze, ferric sulfate, for the purpose of number one, hemostasis, preventing bleeding. Number two, preventing the root and filling material from scattering into the cavity. Number three, I'm gonna mix the material into the work consistency and applying it with special applicators such as amalgam carriers. They actually MTA applicator is like the amalgam carrier but smaller, which should apply it into the retro cavity and condense the material properly with special angulated condensers. After filling the material increment by increment, I should finish the material, get a dampened gauze with a bit of saline, remove all the flashes of MT on the root surface, and I inspect the root end properly. What should I see? I should see a look such as the picture on the right. I have the root cross section rounded, all of it is clean, and in the center there is a rounded button or white button of MTA. There is no scattered particles on the root surface or in the cavity. The root surface is all clean except from the central retro preparation, which is completely filled and condensed with MTA. After this, I should remove the gauze or the bone wax or the material that I'm stuffing into the bony cavity. I should take a radiograph and check for proper preparation, density of filling, and if there is cavity flushes or not. The cavity should be totally clean with no flushes in the bony cavity. This is the difference between traditional surgery, microsurgery. Regarding the size of the cavity, traditional surgery size of the cavity was large, can be seen by naked eye for sure, because the instruments and tools were very large. As for microsurgery done under microscope, it's very small in size. The tools for traditional surgery, round and inverted burrs, were very large, and actually the tools for microsurgery are very small ultrasonic tips, angulated and very convenient. As for traditional surgery, the bevel was 45 degrees so that the operator can see the canal and make the preparation. As for microsurgery, doesn't need to make a bevel. There is a microscope, angulated instruments, so the bevel is between 0 and 10. The internal tubules are cut more in the traditional surgery, and the cavity preparation is very shallow, not centered, with possibility of perforation as we mentioned before. However, in microsurgery, it's deep, centered, precise, and very clean. The root and filling material for traditional surgery was the earliest materials such as amalgam. But for microsurgery now, MTAs and recent materials, bioceramics, are used. As regarding the suture, for traditional surgery, there were large size sutures, 3-0 and 4-0. It was made of silk, which is non-resorbable, need to be removed after 7 days. However, for microsurgery now, we have 5-0 and 6-0 monofilament resorbable sutures. They are very fine, very good for aesthetics and produce better healing. So for the healing, for sure, microsurgery is better, and the success rate for microsurgery is more than 90% when compared to traditional surgery, which is less than 50%. After this, we come to the flap repositioning and suturing. We should reposition the flap again in its place, making some massage with a damp gauze to allow the circulation to flow and the tissues to go back to its place. Actually, a lot of factors affect the repositioning of the flap. One of them is the time factor. The fast you finish, the better will be the outcome. The second one is the retraction force. You should not retract the tissues forcefully, or then it will be teared, or the blood supply may be cut off it, and the repositioning will be very, very bad. The flap will shrink and it will not return back to its original position. Avoid stretching, avoid pulling, and as we said, as much as we can, less operation time. Now we are going to talk about the sutures. There is a large number of styles of sutures. We are gonna take 4 or 5 types. The first one is the interrupted suture, means each suture is made alone. Sutures are not connected. This type of sutures is easy. I take each one aside. I don't connect the sutures. Good in adaptation. Pardon me. And if one suture breaks, the other sutures will be fine. They will not be disturbed. But as we said before, nothing is fully ideal. There is advantages and disadvantages. These types of sutures are time consuming. I make a suture, then I cut, then I make another, then I cut, I make another, then I cut, and they have many knots. These knots actually collects food and debris, especially for patients that are not good in taking care of their oral hygiene, and they need to be removed after 7 days. How do we make this suture? I take my needle from the free to the attached. I enter in the interdental papilla from the labial side, then I got the needle from the lingual side, then I pass my suture thread again to the labial side, and I make my knot. What is the serial of working in this suture? First, I take what is called 2 interlocking sutures. I take the first interdental papilla of the incision and the last one. This is to secure the flap. Then I take the all the interdental papillas in between, and then I take 2 sutures in the 2 vertical incision, 1 suture in each vertical incision. The continuous matrix suture of the angle of weave and the gaps and overlaps, the continuous blanket suture arises. This suture is perpendicular rather than angled. they're able to hold the edges better with less torque on the tissues. Now there is no angling, there is no overlapping. They are easy to place and kept clean, not much notches. The continuous sling sutures, and this type of sutures actually is used to close long intracellular flaps. Okay, it's called modified mattress. It's very good in stability. The basket suture, and this is such as a sling suture but for one tooth. I actually go from the facial or labial side, I go around the lingual side of the tooth, and then I go through the labial side of the other side of the tooth, and I go back along the lingual side, and I will finalize it again in the first labial or facial side. I rotate around the tooth. The last one is the crisscross continuous suture, and this is used for vertical incisions and for securing incisions. Many surgeons use these sutures for closing over implants, for closing over teeth that were replanted, for grafts. It's very good in stability. Removal should be after 48 hours, because if we extended the time after 72 hours, it will be covered with bacterial mat, causing irritation of the wound. What about the post-operative care? I finished my operation totally sutured, everything is good. I took my x-ray. What are the instructions that I'm gonna tell the patient? First of all, I should compress the surgical site with damping gauze to reduce the clot thickness and achieves hemostasis. And this clot will be differentiated further and causes regeneration of the area. Then I should instruct the patient to put ice packs for the next 24 hours. The patient should put the ice pack on for 20 minutes and remove it for 40 minutes. Then on for 20 minutes and remove it for 40 minutes. This is for 24 hours, the first 24 hours. Why? To reduce the vascular rebound, the swelling, the edema, and increase the analgesic effect. Sure, no smoking on the day of surgery, and the patient should avoid anything that's hot foods, hot beverages, and he or she should eat on other teeth, not on the teeth that you operated on. After 24 hours, warm saline mouth rinses is very, very helpful. It starts after 24 hours, or chlorhexidine mouth rinses. Actually, these warm saline rinses help the circulation, helps the repair and healing, and washing away of any irritants. I should instruct the patient to brush gently the day after the surgery, but not to neglect the brush at all. And I should prescribe an appropriate analgesic and antibiotic if needed, if there is an infection. The last part of our presentation is the corrective surgery. And the corrective surgery is done to correct a defect in the body of the root rather than the apex, such as perforation repairs and periodontal repair. Perforation repair, if the mechanical in the perforation area, I can repair it with MTE. Actually, the repair and the prognosis will depend on the size and the site of the perforation, the ability to achieve hemostasis, proper isolation, rubber dam is a must, and the time factor, actually the time from which the perforation occurred to the time you see the perforation. As the size decreases, it's better. As the hemostasis is achieved, it's better. Better isolation gets better results, and less time is better for prognosis. If the perforation is stripped or along the root length and small in size, we can immediately seal it with MTA or super EPA, internal or external by surgery. But if it is large, actually it is non-restorable, so I may need to remove this root in which the perforation occurred by hemosectioning or amputation. If the perforation is apical, we can go through the periradicular surgery as in the previous section. If the perforation is resorptive, treatment will depend upon the presence or absence of oral communication. If there is no oral communication, I can do recalcification with calcium hydroxide, as we all seen in the root resorption chapter, or with a corrective surgery. I can make a single or double vertical flap, exposing the site and removing all the resorptive, cleaning the resorptive defect, putting materials to kill all the remaining resorptive cells, removing granulation tissue, and restoring with a proper root repair material and closing my flap. Decrease the infection, and then I observe. If there was a communication between the resorptive defect and the oral flora, if the region can be approached labially, I should do a surgical flap and close it with a material that sets immediately, such as the jerry store or composite. If the lesion is on the lingual side, I can do gingivectomy and expose the lesion and also restore. And I should never forget that my first option should be periodontal regeneration or guided tissue regeneration. Then, if it doesn't work, I will go for a resective approach. And my last option should be extraction if the tooth is doomed. This is a video showing a live periodontal surgery with all its steps. The preoperative video, as we can see the lesion. This is a microsurgery. This is a microblade, and as we can see, the surgeon starts to make the incision. The incision is deep down to the bone with the microblade. This is the circular incision, as we can see, deep down to the bone. Then he will start to make the vertical incision. Actually, in such surgeries with that lesion size, we should do 2 vertical incisions. However, the surgeon here in this surgery preferred the triangular flap with 1 vertical incision. But actually, the better for accessibility and visibility will be the rectangular flap. As you can see, he's elevating. This is a periosteal elevator, and he is scraping the bone to avoid leaving periosteal tissues that cause bleeding and improper healing. This is the retractor. It retracts tissues for better visibility and to avoid the flap injury. You can see the lesion here popping out of the fenestration in the bone. Now we're trying to correct the lesion. Comes out in fragments. And the root apex started to appear. Can you differentiate between the color, the yellowish color of the root apex and the bony cavity, or the color of the bone? Trying to mutilate the lesion, but there is some lesion behind the bony the root end, so he's going to make episectomy. Actually, we prefer to make episectomy with a tapered stone with round end, not that round. He made the episectomy, as you can see, cut the root end to be able to gain access to the lesion behind the root. Can you see the gutapercha in the canal? This is the canal, and the cross section of the root. This is a step called conditioning. They sometimes condition the root with acids for proper disinfection and opening of the entire tubules, removing the skin layer. Now the root apex and the tuberca, removing the rest of the lesion. This is the retro tip. He will start the retro preparation. As we can see, goes inside the root end to a depth of 3 mm, removing the tuberca in the apical 3 mm, as you can see. Condensing the remaining tuberca inside the root. You can see the preparation, very precise. Now packing the cavity with the materials such as those, as we said, to stop the bleeding and avoid scattering of the retro preparation into retro material into the cut. This is the retro material. This is an MTA applicator, injected the first increment, and we condense the increment by condenser, integrated condenser. Then injecting the second increment and also condensing it until the retro cavity is totally filled with the retro material, which is empty. The third increment. Again condensing. And then he will clean, condense it with a burnish it with a burnisher, and clean the root surface totally. And this is the end. As you can see, the MTA pack, you cannot differentiate it from the tuberca. And this is the suturing. As you can see, we will take from the labial or facial side, pass it to the lingual side or palatal side, and we'll pass it again from the palatal gingiva to the labial side, and he will make the lock of the suture. This is the first one, and he will make the second one, then cut. First knot and second knot, and he will cut. This is the interrupted suture, as we said before. Each suture is totally independent of the others. It's time consuming, but actually when one suture breaks, the others remain in their places and are not touched. And this is the vertical. He took 4 sutures for the vertical, which is too much. This is 1 week follow-up, as we can see. Very good healing. He was using a very fine monofilament resorbable thread, suture thread, maybe 50 or 60, which enhances the healing and better for it. Thank you very much. انا عايزه اقول لكم ان انا بجد مبسوطه جدا ان انا كنت معاكم السنه دي. ربنا يكون معاكم ان شاء الله باذن الله، وتتخرجوا على خير ان شاء الله باذن الله، وتفتكروا الايام دي وتنبسطوا، وربنا يوفقكم كلكم ان شاء الله باذن الله في حياتكم، واتمنى اشوفكم دايما على خير. وجود لك يا شباب.